Hello my dear students. So today we are going to discuss development of rectum and anal canal. These are cases you will come across routinely in your surgical practice. I am Dr. Vaishaly Bharambe. I have been teaching anatomy for more than 25 years and I love it. It's my honor and privilege to present this topic before you, which I know is clinically very important. Just understand that if you like the lecture, the notes and MCQs related to each topic are available on my website vbanatomy.com. So it's not like that you shouldn't watch the video, but sometimes after watching a video you might like the slides and then you will feel that I want these. So if you want to go through them, then you can go on the website. All this written material is made available in the form of handouts. So you can go through them at your convenience. Of course, do watch the video again, it will give me great happiness. Alright, let's begin the topic, development of rectum and anal canal. So first, let me place before you a case. Okay, so let's see how with development we will solve this case. So the case is, a female infant was born with a dimple where the anus should be. That means the child had no anal canal. Okay, examination of the infant's vagina revealed meconium in it, an opening of a sinus tract from the posterior wall. So what do? We do a radiographic examination and a fine tract was revealed connecting the vagina to the rectum. Okay, so this was a fistulous connection. Question: with which part of the lower bowel would the fistula be connected to? Yes, we know it will be, because as meconium, it has to be connected to the rectum. So what is the birth defect called? It's called as rectovaginal fistula. See, till here it doesn't take that much sense. It's easy to understand. Question is, what is the embryological basis for this condition? What happened? How did it happen? To understand that, we need to understand the development of rectum and anal canal. So first let me show you the developing embryo. So here is a developing embryo. Okay, so here is the hindgut. You remember what is hindgut? Okay, foregut, midgut, hindgut are the three parts of the gut tube, which is actually the yolk sac which is enclosed within the developing embryo. Just remember hindgut. Okay, the hindgut is suspended from the dorsal mesentery by a double fold of peritoneum called posterior dorsal mesentery. See, keep following the arrows, which contains the inferior mesenteric artery. Now all of you, I am sure you know that dorsally in the embryo there is one aorta that gives out celiac artery which supplies foregut, superior mesenteric artery which supplies the midgut, and the inferior mesenteric artery which supplies the hindgut. So the hindgut which we are focusing on will always have supply from inferior mesenteric artery and its branches. Right. So there is something called posterior intestinal portal. Let's understand that. So here is your posterior intestinal portal, which is the point where midgut becomes continuous with the hindgut. Midgut becomes continuous with the hindgut at the posterior intestinal portal. What is this? Where is it in the adult human being? So observe over here. This is the right 2/3 of transverse colon, left 1/3 of transverse colon. At the junction of these two lies your posterior intestinal portal. In this diagram, it lies here. So this is the midgut. And this, my dear students, is the hindgut, which now continues downwards and communicates with the ectoderm at the cloacal membrane. So we have learned some terms. We have learned what is hindgut. We have learned primitive dorsal mesentery. We have learned inferior mesenteric artery, posterior intestinal portal. Then we have learned about cloacal membrane. Remember this. This is the basic, on the basis of which you can create a lot of things. Okay, right. So revise. Focus here. This is your posterior intestinal portal, therefore above is midgut, below is hindgut. This is your hindgut communicating at the exterior through the cloacal membrane. This is your posterior dorsal mesentery. That's your inferior mesenteric artery will be coming out from this dorsal aorta. And now one more term. A small projection called as Allantois extends forward in the form of a diverticulum from the anterior wall of hindgut forwards to the umbilical region. Okay, so all these are terms you have to understand if you have to understand development of rectum and anal canal. Okay, right. So this is the Allantois. Just take a look at how it's communicating from the anterior wall into the umbilicus. So at the point where the Allantois is attached, were you to draw a horizontal line, then you would see that the hindgut gets divided into a pre-allantoic part. Does it make sense to you? Pre-allantoic part and a post-allantoic part. Okay. So now we've got hindgut is equal to pre-allantoic plus post-allantoic, two parts, right? So the pre-allantoic part of hindgut, what does it develop to form? The pre-allantoic part of hindgut, take a look at the developed diagram. It gives rise to left 1/3 of transverse colon, descending colon, sigmoid colon, and part of rectum above the middle rectal valve. You remember Houston's valves? Okay, so the middle valve, everything above that is pre-allantoic hindgut. Now let's go to then what develops from post-allantoic hindgut. Post-allantoic hindgut gives rise to rectum, easy. Anal canal, yes, easy. But it also gives rise to urinary bladder and urethra. How do we explain that? So let's now begin to develop post-allantoic part of hindgut. Pause, drink a sip of coffee or whatever, your tea, whatever, relax. Development is beautiful. Look at it and understand its beauty. Don't just do it because somebody expects you to know embryology. I find embryology so gorgeous. It's such a beautiful and logical way of developing a human being. Sometimes there is a mistake, and that's why we see anomalies. Remember, all this that I'm teaching you at some point in the lecture is going to go wrong, and that's when we will develop the anomalies, right? So take a pause. Right. So how does post-allantoic part develop? How does the post-allantoic part of hindgut develop all this? Let's understand. So the post-allantoic part of hindgut slowly begins to dilate to form an endodermal cloaca. See this term, endodermal cloaca. So it was narrow, now it's bulged up. It is communicating at the outside at the cloacal membrane. So where the hindgut meets the ectoderm, there is a bilaminar layer formed which is called as the cloacal membrane. So two terms we have understood. Lower end of hindgut dilated to form endodermal cloaca. Endodermal cloaca coming in contact with ectoderm with a bilaminar membrane called cloacal membrane. Okay, let's take it forward from there. Now I want you to just go back a little and see what's happening. This is the umbilicus, this is the lower end of embryo, okay, and this here is the cloacal membrane. See how initially the cloacal membrane basically is your perineum, okay. So it should ideally be facing down, but what you are seeing is facing forwards. Now slowly the lower abdominal wall between your umbilicus and your perineum begins to grow in size. So what happens? The cloacal membrane which was facing forwards now begin to face downwards and further downwards. Take a look. Forwards, downwards, further downwards. This is how your endodermal cloaca, which was facing forwards along with cloacal membrane, now turns its orientation downwards and further downwards. That's how your perineum comes to lie in your perineal region. Okay? Right. So one more change is now taking place. That change is that this cloaca now begins to, so the cloaca was flat, now it gets curved inwards and a new cavity gets formed below it. This cavity is called as the endodermal cloaca. Take a look, okay? See how it was and now see how it is. It forms a little cavity which is the ectodermal cloaca. This is getting a little serious now, so we are going to revise. So I've got an endodermal cloaca with allantois attached to it. I've got a cloacal membrane which is a bilaminar layer where the endoderm is meeting the ectoderm. There's no mesoderm in between. And I've also got a little depression from outside which is called ectodermal cloaca. Close your eyes, think. Endodermal cloaca, cloacal membrane, ectodermal cloaca. Repeat. Endodermal cloaca, cloacal membrane, ectodermal cloaca. If you know these three basics, nothing can stop you from understanding the rest of the development. Now what happens? You'll be surprised that all these three structures are now going to break into two. Each structure, endodermal cloaca, ectodermal cloaca, cloacal membrane, everybody gets divided into two. Okay, so let's begin the division. Division of endodermal cloaca. Now take a look. This is endodermal cloaca. You can see a urorectal septum growing downwards, okay, between the allantois and the hindgut. As it grows downwards, slowly a bit of the endodermal cloaca stays forward and one bit stays backwards. You can see that in the diagram. Till finally the urorectal septum fuses with the cloacal membrane, okay, and the endodermal cloaca has now got divided into two separate tubes. One tube is anterior, continuous with allantois, called as primitive urogenital sinus. One tube is posterior, continuous with the pre-allantoic hindgut, called as the primitive rectum. Summary. Endodermal cloaca is equal to primitive urogenital sinus plus primitive rectum. Who is dividing them into two? Urorectal septum. Where is it fusing? It's fusing with the future perineum. The point where they fuse is your perineal body. We'll do this again, don't worry. Just pause and think. There is a time when the primitive urogenital sinus and the primitive rectum are in continuity with each other. Urorectal septum has not fused completely with the perineal body. That point is when there is a continuity between the two. That continuity is called cloacal duct. How does it matter, ma'am? Why do you want to teach us all this? I want to teach you all this because sometimes in us, urorectal septum never fuses down. It stops short, and then this cloacal duct remains as that fistulous connection which communicates the rectum with the ventrally situated structure, may it be urethra, may it be urinary bladder, may it be vagina. All these fistulous connections occur because of persistence of this cloacal duct. That's why we should know it. Okay, so let's understand a little bit about urorectal septum. See, urorectal septum look like a nice vertical septum growing downwards. It is, but it is supported by lateral elements. Take a look. Here's your urorectal septum as you understood, and there are two lateral folds coming in called folds of Rathke. As the three fuse together, they complete one urorectal septum. If I take a transverse section, I can see it here. These are the two lateral septa coming in. They are fusing together, completely dividing your endodermal cloaca into rectum and urinary bladder. Okay, just remember one thing. The vertical element can go wrong, the lateral elements can go wrong. Okay, so if it's a high fistulous connection, it will be the vertical element. If it's a low fistulous connection, it will be the lateral elements. Think about it. If your mind is ready to accept this, accept it. Otherwise, just remember urorectal septum and let's move forwards. You saw that we divided the endodermal cloaca into two cavities. Okay, so thus we saw formation of primitive urogenital sinus and primitive rectum. Now whom should we divide? We should now divide the cloacal membrane, isn't it? So this is your perineal body and here is your perineal membrane getting divided into urogenital membrane and anal membrane. Same cloacal membrane. Now you have a perineal body. What is anterior is your urogenital membrane. What is posterior is your anal membrane. Right. Now let's divide the ectodermal cloaca. So this ectodermal cloaca, remember the depression which was formed outside? This also gets divided into primitive urethral groove and proctodeum or anal pit. This is a major landmark moment in our development. The ectodermal cloaca has now got divided into primitive urethral groove and proctodeum or anal pit. Okay. So, what is the raw material now available with me to develop my rectum? Primitive rectum, proctodeum or anal pit, and in between the two, separating them, is the anal membrane. So, take a look. It looks like two cups, one cup kept like this and the other is like this. Separating the two cups is the anal membrane. So, let us develop the anal canal. Okay. So, this is the endodermal cloaca, or you can call it the primitive rectum now. That is the anal membrane and that is the proctodeum. Three players in this development. What happens? Proctodeum now begins to deepen, growing further and further inwards into the body. See that, okay? Then what happens? The anal membrane ruptures, okay? In this case, if this anal membrane ruptures, all the coffee in my cup would drip down, okay? Which is what begins to happen now, okay? So, the anal membrane ruptures. What it leaves behind is a crenated line completely surrounding the upper end of the anal canal or middle part of the anal canal, called as the pectinate line. And who begins to communicate together? The lower end of the post-allantoic hindgut begins to now become in continuation with the proctodeum. Okay. So, your anal membrane has ruptured. Anal membrane has left behind the sign of anal membrane. It is pectinate line. Part above it develops to form rectum and the anal canal. Part below it, okay, becomes the lower half of anal canal below pectinate line, which therefore develops from the anal pit or proctodeum. Upper part is therefore endodermal, lower part is therefore ectodermal. They will behave in that manner. Very, very important. Pectinate line is a line of communication where endoderm begins to communicate with the ectoderm. Right. So, summarize please. This is your pectinate line. Part above pectinate line develops from post-allantoic hindgut. Part below pectinate line develops from anal pit or proctodeum. Okay. And the part where they meet is pectinate line. Now, I have some advice for all of you. All students should correlate nerve supply, blood supply, lymphatic drainage and clinical presentation with this development. Think about it. So, just before we go into this correlation, remember, development of, when we say it is endodermal, we are only talking about the inner lining and the glands. We are never talking about the rest of the wall. If you look at any gut, it consists of mucosa, submucosa, muscularis externa, serosa, MS. So, we are only talking about the M. Okay, the submucosa, the muscularis externa, the serosa, everything comes from splanchnopluric mesoderm. Okay. Just remember sphincterinae externus, which is the sphincter, I am sure you know that, the sphincter that controls to a great extent the defecation. Okay, this develops from myotomes that give rise to muscles of hind limb. So, this explains how the inferior rectal nerve comes here to supply. Okay, think about it. Right. So, let us do that, correlation. Pectinate line is our junction. Above endoderm, below ectoderm. We have understood that much. Now, see how the part which is above pectinate line receives blood supply by artery of hindgut. What is that? Inferior mesenteric artery. Its branch, superior rectal artery, supplies the upper half of anal canal. Venous drainage is by superior rectal vein, which drains into inferior mesenteric vein, which drains into portal vein. Okay. Lymphatic drainage to inferior mesenteric lymph nodes, and very important, nerve supply is by autonomic nervous system. You must be thinking, why is she telling me all this? I don't want to know. Of course you want to know. Because autonomic nerve supply means that any pathology in this region is not going to be that painful. It's going to have a very low level of pain. Let's take it to development of anal canal below pectinate line. Now this is ectodermal. Okay, blood supply is inferior rectal arteries. Venous drainage is inferior rectal vein, which finally drains into the inferior vena cava. Lymphatic drainage is superficial inguinal lymph nodes. Okay, so your anal canal is now draining into superficial inguinal lymph nodes in your groin, femoral triangle to be precise. And inferior rectal nerve gives its nerve supply. What is the peculiarity of this nerve? This nerve is going to give that patient severe pain when there is a pathology. So, outer part of anal canal, when it gives a pathology, when it is suffering from a pathology, the patient is going to have severe pain, it's going to have very sensitive region to temperature, touch and pressure. Okay? So, this is how you differentiate. There is some more. Remember, the surgical importance is that where does the cancer metastasize? You know that anal region cancers are very common. If the cancer is above pectinate line, through the portal vein, it will metastasize to the liver. But if it is below the pectinate line, it's going to metastasize to your lung, through the vena cava to the lung. So you're now able to correlate your, what you're seeing in development with what you're seeing in your patients, in your practice. Do that. Right. So we've done the development of rectum anal canal. Be happy. Be proud that you've understood something which is pretty complicated. Let's now understand what are the conditions you will see. You will see maybe anal stenosis. Anal canal is there, but it's very, very narrow, abnormally narrow. You might see a persistent anal membrane, which means basically your anal membrane never ruptured. It can be a thick persistent anal membrane or it can be a thin persistent anal membrane. You will see anoperineal fistulae. So what happens that the lower end of cloacal duct may persist. It communicates the rectum down to the perineal surface. Instead of communicating down with the anal pit, the communication is with the perineal surface. Okay. So you can see here, you can see that here, this is the anal pit and you can see the anoperineal fistulae forming here. This is in the male, this is in the female. Right. Let's go to the. So, like I said, if it's a high fistula, it will be a vertical element problem. If it's a low fistula, it will be a lateral element problem. Right. What's happening here? I know it's fun for us because we are medicos. It's not at all fun for the poor child. Okay. I think long time ago, this actually was not associated with survival at all. The child would die because child had no way of expelling the abdominal contents. You are seeing the rectum is communicating with the urethra, high rectourethral fistula. Here you are seeing the rectum communicating with the vagina, rectovaginal fistula. Okay. And now we are seeing one case of rectal atresia. Lower part of rectum has not developed at all. There is rectum developed here and there is anal pit or proctodeum. In between there is nothing. In today's world, the walls of the gut are created and communication is created. It may take time, but these surgeries finally result in a healthy, happy baby. Thank God that we have developed all this. Right. Let's come to one more condition called as a Hirshsprung's disease, when the wall of the gut tube does not have development of the sympathetic and plexuses. So what happens? The nerve plexus in the wall does not develop. So the peristalsis brings food to that point, but the food is unable to pass forwards, resulting in a gradual dilatation of that portion. It is a medical emergency most of the time. There have been cases where it is partial and therefore certain survival, the child continues to pass motion, but child is usually having trouble in passing motions. So let's come back to the point how we started our class. We saw that there was a rectovaginal fistula and our question was, what is the embryological basis for this? Now we know that rectovaginal fistula is likely to be persistent cloacal duct, non-development of distal end of the rectum. The lower post-allantoic part of hindgut has not developed and the cloacal duct persisted. So there is a communication now between the developing rectum and the developing ventral structures, may it be vagina as in this case, may it be urethra if it was a male. That is the explanation that we have for this kind of rectovaginal fistulas. So to summarize, what did we learn today? We learnt about development of rectum, development of anal canal, we talked about developmental anomalies, and I have also tried my best to help you understand how to surgically correlate what you see with what is the development as you understand it. And finally, we've also tried to solve one developmental problem. These are very commonly asked in NEET exams and your PLABs and which are the other exams that you commonly give. So try and solve these problems with your understanding, not by mugging up the possible answer. Remember again, all these notes and related MCQs are available on my website vbanatomy.com. Please access them to read some more. If you want to learn more about surgical anatomy of anorectal region, please see that video. The link is given in the description section. If you enjoyed this lecture, do like and subscribe, and it will encourage me to create more of these videos for you. Thank you, my dear friends. I'll see you across the screen in some other video. Bye.